TopMedTalk.
Well, hello and welcome to TopMedTalk. We're coming to you live from the World Congress of Prehabilitation and Perioperative Medicine, which is being held in conjunction with the Australian ERAS Plus conference here in Melbourne, Australia. I'm Kate Leslie and I'm here with my co-host, Mike Grocott. Hi Mike, how are you going?
Very good, Kate. You can hear in the background the lunch. It's a great meeting they organise here, but it's long. So at 8 in the morning till 5 in the evening, 6 in the evening sometimes, and the delegates clearly need their lunch, so they're tucking in.
So we're very fortunate today to have a fantastic guest, David Waters.
David Waters, I'm a general surgeon, a professor of surgery at Deakin University, and I work at the University Hospital Geelong. And for the last few years I've been director of surgery at Safer Care Victoria, which is a sort of seconded part-time position, which is, for those people not from Victoria, Safer Care Victoria is the safety and quality arm of the Department of Health in Victoria.
And what are the major things in the Director of Surgery at Safer Care Victoria?
Well, the role was created to support the safety and quality aspects of the planned surgery and reform agenda. We were recovering after COVID when the waiting list, as we called it then, it's now called the preparation list, increased from some 40,000 patients to over 80 and almost 90,000 patients. So in trying to increase activity, we also wanted to make sure that we improved or did not lose any safety and quality and did not just do more work, but do it not as well, and the patients get the outcomes they want.
So what are the major streams of work that you've got going now?
One of the major things that it achieved was really to promote more day surgery and to also show that patients actually prefer to go home if they feel safe to go home, and then they are safe to go home. So we've operations like hernia repair and cholecystectomy were often not being done in Victoria as day cases when they were being done in many other countries of the world and also in other states of Australia. So we increased that, and we've been able to show that that's gone well. We've also promoted non-surgical options for patients in whom not having surgery is actually maybe better. Very good example of that would be people having operations for carpal tunnel or trigger fingers, where hand therapy, if particularly if given early, is far more likely to be successful in up to 40% of cases. And so we promoted that, and some of the health service partnerships in Victoria have taken up that option. The department established patient support units that got in touch with people who were on this preparation list and talked to them about whether or not they still needed the surgery, whether they wanted to try alternatives. And quite a number of people were taken off the planned surgery wait list because they'd either improved or they were happy to try alternatives, and those alternatives were successful. We also promoted enhanced recovery after surgery because that clearly reduces complications, reduces length of stay, and actually helps patients themselves to engage in their own care. And we promoted preparation for surgery, changing that waiting list to preparation list and promoting prehabilitation. And I think an engaged patient is always one that is more likely to get a better outcome when they understand what they need to do. And we promoted virtual surgical schools, education of patients before surgery.
I mean, great set of innovations. So you must have come across ERAS for the first time maybe 20 years ago? And I'm guessing that it's not the first time that it's been introduced, at least in one or two hospitals in Victoria. And I guess that means it hasn't been sustained. If you've still got opportunity to improve, how would you maintain and sustain this over time?
So that's a really good question because, in fact, my hospital was one of the pilot hospitals along with the Alfred Hospital, setting up ERAS for colorectal surgery more than 10 years ago. And all of us who do colorectal surgery thought, ERAS is working. And then when we appointed an ERAS coordinator who actually audited how well we were doing, we found our bundle compliance was around about 50%. So with the reappointment of an ERAS coordinator who got going with all the major colorectal cases, she brought that up to 80% compliance, and we suddenly found that we reduced our length of stay again to 1.8 days. So we just hadn't been measuring our bundle compliance. So I think most people who do ERAS would say that you need to have the data collected and reviewed at least periodically. You might not need to do it all year. You might need to just do it for a quarter of the year or something like that, but you need to review it. And I think an ERAS coordinator does much more than collect data. They actually interact with the patients, support the patients with their questions, and the patients therefore have a much better experience because they have somebody to talk to. That could be done by a colorectal liaison nurse as well, who's duly trained, but I think you can't just do ERAS and just assume that having set the bundle up, it's just going to go for the next decade.
Our experience is that it starts to fail without that ERAS coordinator. As you said, it's not simply data collection, but I mean, it's real leadership. The ERAS coordinator being there and keeping on, just tapping us all on the shoulder and reminding us that is a promoter of that cultural change, which otherwise, for whatever reason, seems to slip back, or at least that was our experience.
Yeah, and look, I think one of the reasons things slip back in healthcare generally is because when you've established the protocol, it doesn't mean to say with registrars changing every 6 months and fellows changing every year and nurses changing quite rapidly too, particularly through the COVID pandemic, you suddenly have a completely different set of people looking after the patient day to day. And just assuming that people know what the protocol is a big assumption. And our health service has certainly shown that it was only an assumption. And I think you need an ERAS coordinator for each program. And I think whether one person can do that job across a couple of 2 or 3 programs will depend on the volume of cases.
So Australia is a federation of states, and we have a national insurance scheme, and we have public hospitals that are free at the point of care. But we also have a very substantial private hospital sector. So we're a unique country in some ways, but there are similarities with other countries overseas. In Victoria, how is Safer Care Victoria working with private hospitals to introduce ERAS bundles? Because there are different and sometimes perverse incentives in private hospitals.
The private hospitals are ultimately responsible to the Victorian government, to the Department of Health and to Safer Care Victoria for the safety and quality of the programs and the operations that they provide. But there are obviously far less levers to influence the private sector unless things go wrong. So I would have said that too much of our interactions with private health services, and this is not necessarily their fault, this is the system in which we work, is reactive. If something happens, then you talk about how it can be improved. Or something goes wrong, you can talk about how it can be improved. Safer Care Victoria also either puts out guidelines or is willing to co-brand guidelines. And I think that's also a way of setting something up to show people this is how best care should be done. But in the private sector, we probably don't have any ability to monitor those guidelines. And, guideline compliance is a very negative way to talk about it because you really want guidelines to be inspiring. We don't want ERAS to become a compliance issue. We want ERAS to become, let's do it because it's best care and it's going to get the best outcomes for our patients. They enjoy it and the staff enjoy it.
And so how have you worked with surgeons to get them on board? We all know that surgeons love operating, so they may not see a reduction in the number of patients coming for surgery as being particularly what they'd like to see. So how did you engage with your surgical colleagues to get them on board with the ERAS programs?
I think one of the ways in Victoria that the surgeons have worked together, particularly in the public sector, is because during the COVID pandemic, we started a meeting of Victorian surgical directors in public hospitals. We had the private hospitals there too because they were also looking after COVID patients. But ongoing with the recovery and reform program, the Victorian surgical directors have continued to meet monthly. And so if there's something of importance, it gets onto that monthly meeting and we get those people who are piloting something. For example, we did this with day stay cholecystectomies. We got the 5 centres that were already doing it to talk to the ones that weren't, and they took it up because Victoria is a fairly small place. There's only probably 6 million people in Victoria. there's really probably only about 18 really big hospitals. And so it's quite easy to get those people together and to get a consensus and to agree. They've then got to do the more difficult job of getting their colleagues to agree. That takes negotiation, leadership and championing.
I'm always struck in the UK when we compare the private and public sectors, the efficiency of operation in the private sector with exactly the same individuals seems to be much improved. So they literally walk across the road in the afternoon. They're managing a throughput that is greater than the public sector. And I get the impression there's some of that in Australia as well. Is there any way we could sort out the public sector to work as efficiently as the private?
Well, one of the ways in which we have been doing that a little bit in Victoria during the last couple of years has been to fund from the public sector more public and private work. They're keen to take on, in the absence of a COVID pandemic really raging, they're keen to take on the lower acuity stuff. And that's a way of getting a lot of volume work done quite efficiently, where the patient stays in hospital a short time and where probably the investment, you get a big return of investment. I think the public sector is better set up to deal with the multiply comorbid patient who's really complex, because it's probably easier to get multiple teams together, and if the patient's going to need ICU and you don't know how long that's going to take. So we haven't tended to put the sicker patients or the more complex patients into the private sector. And I think that one of the things that the public sector does better than the private sector at the moment is multidisciplinary review of complex patients up front, preparing them for surgery rather than just the surgeon putting them on their private list and the anaesthetist either seeing them or phoning them and talking about and deciding their fit.
So an integrated approach with really smart triage between those two systems might be the sweet spot.
Yes, and look, that is certainly something that the government have allowed public hospitals to continue doing since the investment has finished, the 2-year investment. We're now working more. We're able to fund operations in the private sector, but that's now the decision of the individual health service, and a number of them are doing that.
Fascinating.
So what's coming up in the future, finally, David? What's the next big project for the Director of Surgery at Safer Care Victoria?
We're trying to catch up on some of the big complications in surgery, and they are actually medical complications, and we're really focusing on pulmonary emboli, myocardial infarction and stroke, because they have anticoagulant and thromboprophylaxis issues, and they are really serious when they occur, and a number of them occur after discharge from hospital and may even be readmitted to a different health service. So we've set up with the Safety and Quality Dashboard method of tracking those patients within 30 days of their index procedure so that we can let health services know who's having these events. The Victorian Perioperative Consultative Council have established a tool to review those cases at the local level, and that's not a lot of work because there's not a lot of these issues happening for any one health service, but they're really important to the patient when they occur. So that is certainly one thing that we're promoting through Safer Care Together's Safer Together program. The other thing we're going to do is to look at complex procedures such as esophagectomy or such as cystoprostatectomy and really decide where should they be done and should they be done in less centres. This is something that's been raised by upper GI surgeons in the case of the esophageal resections, because we don't do a huge number of, we only do about 140 esophageal resections a year in Victoria, and so we're sort of setting up complex procedures and complex problems committee that will look at those with the relevant stakeholders at a lower level and make recommendations to the government. And the third thing we're doing is Victoria's now set up a surgical capability framework where health services are graded 1 to 6, and we're going through a process of discussing with health services at the moment what they think their level of capability is, and then we're really going to try to make sure that the right patients get done in the right place. We're not trying to stop health services doing things they're doing well. They can apply for exceptions, but with the establishment of partnerships moving to networks. We really want to see cases being moved to where they could be done really efficiently and let the higher acuity hospitals really focus on either complex patients having simple conditions that will need that higher acuity hospital or more complex patients.
You're going to be very busy in the next 5 years with those great initiatives. We'd like to thank you for coming on TopMedTalk, David, the broadcasting arm of EBPOM, which is evidence-based perioperative medicine. You can find this podcast on any podcatcher or on our website, and you can go to our socials to look us up. And if you go to YouTube, please give us a big thumbs up. That every little bit helps. We'd like to thank our sponsors, and I'd like to thank my co-host, Mike Grocott.
It's been a pleasure. Thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.